which, when properly handled, would be a powerful vasoconstrictor. And now we begin to get industry interested in this. Now we move to Sao Paulo, where a professor of pharmacology, Ferreira, so it's in the faculty of medicine, what is it? Ribeiro, tell me. Okay, he said it better than me. So Professor Ferreira made a remarkable discovery, and we're back to academia. He found that the venom produced by this horrible-looking snake really acts by causing vasodilatation. Because it potentiates a natural vasodilator, bradykinin. So he discovered that in the snake, in the venom, and that's how the snake causes a fatality in whoever it bites, because it potentiates bradykinin, which produces massive vasodilatation and usually paralysis. So Ferreira takes this, and he now moves to London, where he continues his work, and he's working with John Vane, a Nobel Prize winner. And again, we're still in academia, and he found that this bradykinin potentiating factor, which is a crude extract of the snake venom, and this is the key finding, and this is how it begins to tie together, inhibits the peptidase, which converts angiotensin 1 to angiotensin 2. So this was an extraordinary discovery, because now it finds that we have a substance that increases vasodilatation and that prevents vasoconstriction. So now a vasodilating and a vasoconstrictor substance are part of the same system. And of course, now we come back to industry, and when industry finds or discovers that there is an important regulatory system, can we block it? Well, at the Squibb Corporation in Princeton, New Jersey, now Bristol Myers Squibb, but at that time Squibb, first orally active angiotensin converting enzyme inhibitor was found. That was Captopril. So it's interesting. So the basic discoveries were done in the academic world, and then industry sees the opportunity. They see the opportunity of blocking this, and they come up with the first ACE inhibitor, and of course there have been many others. Captopril was a very important drug, but it didn't have a long life from a financial point of view. And the reason was because it had a short half-life. It required 3 times daily. And lots of people who are hypertensive, they don't have any symptoms. Hypertension, like cholesterol, is a silent killer. They can take something twice a day, like Enalapril, but they won't remember that they have to take it 3 times a day. So anyway, but this was a major breakthrough. And then we moved to Enalapril, which is a twice-a-day drug, very similar to Captopril. And now we have really the first important clinical trial, and important it was. So this is the effects of Enalapril on mortality in severe congestive heart failure, and that was done by a Swedish group called the consensus trial study group. So that was an academic group at Gothenburg, and the company was Merck, because they jumped on Captopril and came up with Enalapril, which of course has had a much happier existence. And you can see there's 25% reduction. This is a very sick group of patients. You can't see this clearly, but the mortality in a year in the placebo-treated group, the top line, was 60%, and it was reduced by 25%. So this is, it was a terrific winner, just like LCZ is. But this changed the treatment of heart failure, and for that matter, the treatment of hypertension as well. Okay, now we move to Canada, and Professor Adolfo de Bold, who was born and had his early training in Argentina, and was working at Queen's University. And de Bold was a pathologist and an electron microscopist, and in the early days of electron microscopy, and he noticed that there were granules in the atria of rats. And he thought that they were sort of funny looking, and he speculated in one of his early papers, which is now in the late 1970s, that maybe these granules release a hormone or a protein substance, whatever. He became very interested in that, and treated rats with different degrees of salt intake. And in a paper published in 1981, and you can see what a primitive publication this was. So this is a typewritten paper, which was set in type, and I think was one of the most important papers in cardiovascular science in that part of the 20th century. So he really repeated the Tigerset study, except he used rats, and he used the atrium, and so he found the opposite. Tigerset found in the kidney there was something that raised the blood pressure, which we know he called renin, and which we know worked through the renin-angiotensin system, which we just talked about. And de Bold found something in the atrium that had the opposite effect. So this was a diuretic, it was a natriuretic, and since then it's been found to be anti-apoptotic and also anti-fibrotic. And so this really set up a new concept. Now we move to Sheffield in what used to be called the United Kingdom, and we will know tomorrow whether it's Little England or it stays the United Kingdom. I hope it stays in the United Kingdom. So Professor Kenny found that that this atrial natriuretic peptide that de Bold had isolated from the atria, that had this natriuretic and diuretic effect, could be hydrolyzed, could be destroyed by an enzyme called endopeptidase. It has been given another name, namely neprilysin. And that's how we come to neprilysin and its inhibition. And then we move across the channel, and we find in a group in Paris, again academic, an inhibitor, thiorphan, which is an inhibitor of neprilysin. Okay, so let's sort of review where we are with the natriuretic peptide system. Heart failure causes atrial distension. Atrial distension, as the bold showed in his rats, released ANP. Now that ANP doesn't have much of an effect because the enzyme NEP, neural endopeptidase, is present in the kidney. Actually, it's present in many tissues. Breaks it down. And therefore, there is very little vasodilation, very little diuresis, and little natriuresis. If you give an injection, a bolus injection of atrial natriuretic peptide to a normal human adult, it has a half-life of 2 to 3 minutes. So it does these great things, but it's gone. And it's gone because of the presence of this enzyme. So what does industry do? It produces an inhibitor of this, and if you inhibit this, then you get the full effects of the release of ANP, causing vasodilatation, diuresis, natriuresis, I told you, anti-apoptosis, and anti-fibrosis. Well, so the next step taken by industry is maybe you can take these two systems, which really go in opposing directions. Maybe you could merge them together. And a drug was created called by Bristol Myers Squibb. So the same company that came up with the first ACE inhibitor, with Captopril, now comes up with a drug which combines ACE inhibition and neprilysin inhibition. We can leave out the APP. And this drug was found to be extremely effective at lowering blood pressure, and it was developed mainly as an antihypertensive drug. And now we're talking about 2000, the year 2000 or 2001, and thereabouts. And the analysts of the pharmaceutical industry say this is going to be a blockbuster drug. Blockbuster means more than $1 billion a year in sales in the first year. And the papers that described it looked very good. Then a large trial was done, was carried out. The FDA insisted on it was about 25,000 patients with hypertension, and the trial showed a certain toxicity, angioedema, and this causes the upper airways to become edematous, and that can cause airways obstruction and sometimes choking and occasional deaths. So it's an extremely serious, when it's severe, it's a very serious complication, and it was seen in about 4% of African Americans and about 1% of Caucasians. But that was enough to kill it. So this class,